So assessment of beta blocker interruption 1 year after uncomplicated myocardial infarction on safety and symptomatic events requiring hospitalization. I'll just come to the conclusion. This study did not demonstrate the safety of beta blocker interruption in MI patients with preserved LVEF that led to a higher rate of hospitalizations, especially in hypertensive patients. Beta blocker interruption did not improve patients' quality of life and increase blood pressure, systolic, diastolic control, and heart rate. Basically, I think this is a completely medical issue. I will request the cardiology friends to take over on this part of the subject.
Yes, I request Sir
Yes.
Phillips.
So yeah, this is a strangely a few months back in PCR, we had a trial. It showed a registry data which showed beta blockers may not be giving us survival benefit and any positive effect in patients post MI if we continue for lifelong. And this is just a kind of a somersault on the result aspect, where it shows if you stop beta blocker after 1 year, you are going to lose out patients and chances of adverse events will be higher. So, but the common practice is to use beta blockers, and that is being upheld in this trial again. So it's just a kind of a reaffirmation of our belief and faith in beta blockers and the initial studies which proved the benefit of these beta blockers in post-MI setup. Dr. Nishant, what is your take on beta blockers post-MI?
Yeah, so post-MI, we usually give beta blockers started to a maximum tolerable dose according to blood pressure, heart rate. And once the patient is stabilized on beta blockers, I think very rarely somebody stops it at a follow-up of 1 or 2 years. And actually, stopping it or withdrawing it becomes very difficult for the patient. He will come with palpitation and high heart rate eventually. So once it is stabilized, the patient is stabilized on a particular dose, we usually don't touch that.
Yes. So the problem and the confusion started because in chronic heart failure patients, beta blocker has not proven its efficacy in more than 40% ejection fraction patients. But in post-MI patients, all subgroup, even there are more than 40, 50. So what is different in post-MI patients? Once the revascularization is done, one angioplasty is done, or say we have not done anything, even then 40%. So this chronic heart failure, and how come these post-MI patients become different? So there lies some confusion. Okay. More than 40%, what should be the fate of beta blocker? Okay, say if the patient has ischemic heart disease, MI, till 1 year we gave the patient to get benefit and remodeling. After 1 year, the patient looks like similar to chronic heart failure patients, isn't it? Then there is no relevance from the heart failure therapy HFrEF perspective. So there was the basically dispute, and this dispute still holds, and I really don't know. But post-MI ischemic substrate, beta blockers, always there is a kind of hint of benefit remains there.
Somehow I was always taught that once a patient gets stabilized on beta blocker, it's not meant to be stopped.
Yes.
So I am always reluctant to discontinue because I have a fear that should the patient have a myocardial reinfarction, then I have a lot to answer. So
there can also
if it is,
and all.
Yeah.
Dr. Kalyan can also give some input on this beta blockers post-MI patients with heart failure ejection fraction of more than 40%.
I don't stop beta blockers, particularly in patients even in severe heart failure. Even if there is an indication to stop, we used to reduce gradually, not suddenly. We don't stop.
Correct.
Most of the patients are continuing the beta blockers.
So we practice in the same manner.
Yeah.
Yes.